Yeah. Yeah, buffering is real. Chad, you've had similar experiences?
Yeah, we used it for um, that one bone grafting case, and we used it because it was going to be a longer procedure, but she could only use carbocaine because she had a heart issue that her doctor said to avoid epinephrine if possible. So we did it for the carbocaine, and it seemed to work out pretty well.
Right. Yeah, I think we had her numb for 2 hours, 2.5 hours
At least
at least. Yeah.
with just a couple carpules of carbo.
Yeah. Cool. All right. So I want to share my screen. There were a couple questions that popped up today that I thought would be relevant to our conversations tonight before I pick back up where we left off for the adhesives conversation. Muscle relaxers. So let me go to the slideshow. Chad, can you give me a word? Just let me know you see the screen.
Yep,
Perfect.
all good.
All right, so cyclobenzaprine and Flexeril in the dental practice. I'm going to go over how I use it. It's not something that is used all of the time in every clinical practice. With that said, it has its place. Uh, First and foremost, it works in the central nervous system. And the reason that's important, understanding where our medications work helps us to understand what the side effects might be. The medication is not working locally. So, where are we most likely going to prescribe Flexeril? Myofascial pain disease, MPD, which is essentially a fancy diagnosis for Charlie horse of the masseter. Charlie horse of the masseter. A tight masseter, maybe a tight temporalis. Those are the times when we're likely to use cyclobenzaprine. Well, the medication doesn't necessarily work at the location. It's not working at the muscle level. It's not a calcium channel blocker. It's not a sodium potassium pump inhibitor. It's actually working in the central nervous system. And the reason that's important, when we know things are central nervous system depressants, we want to be careful about other medications that they might be on that are also CNS depressants. So that's why I underline this here. Cyclobenzaprine is sold under the brand name Flexeril. They come in, I meant to put it in here. I know they come in 5 and 10 milligram tablets. I can't imagine you're going to use anything different. 5 milligrams for most people is fine. It's safe, relatively safe. If they're on CNS depressants, you probably don't want to be prescribing it anyways. So it's not like you're going to be prescribing 2 milligrams or 2.5 for such patients. I would kind of delegate or coordinate and collaborate with the primary care physician. But they're used for muscle spasms or Charlie horse. So these aren't for patients who have TMD, chronic myofascial pain disorder. These are for people that have a new set of symptoms. They come in, it's acute in nature, and you're just trying to get them out of the fire so that you can treat them with more routine dental therapies such as night guards, aqualizers, so on and so forth. They're not recommended for more than a few weeks. I typically use them for 7 to 10 days as I'm trying to get the patients out of the pickle that they're in, and then I will transfer the treatment to things that are more applicable in the dental practice. Maybe important to note that they cause drowsiness, dry mouth, and dizziness. And the drowsiness and dry mouth appear to intensify with increasing dose. I don't think any of this is surprising, but I think it's worthy of a highlight. The sedative effects of cyclobenzaprine are likely due to its antagonistic effect on histamine, serotonin, and muscarinic receptors. The serotonin part is where I'll focus, only because many patients are on serotonin reuptake inhibitors, and you might want to be a little bit more careful in prescribing cyclobenzaprine in those patients. It talks about MAOIs. We've all seen this warning. I don't know any patients that are on those, so I don't think they're super common. With that said, very important to have some sort of tool to make sure the medications you're giving don't interact. I would not want to rely on my own memory. I'd rather rely on a objective tool that will tell me whether there's interactions or not, and I'll show you what I use shortly. But there is some literature out there talking about serotonin syndrome, which essentially is an excess of serotonin in the CNS synapses that can cause CNS issues. Definitely not something you want to get involved with. Duloxetine, I believe, is Cymbalta, which is an antidepressant, and phenelzine, I forget what the brand name is, but that's a very atypical antidepressant. Point is, we should have a tool that we use to make sure that drugs don't interact. And when they do, we know how to quantify that interaction and make decisions as a result. Be careful with CNS depressants. So if the patient is on a lot of alcohol, might want to let them know to abstain from alcohol during that period of time. Be careful if you're giving them opioids at the same time. It might be somewhat enticing to give patients with myofascial pain disorder in the acute fashion opioids. We tend to stay away from those for that purpose. I haven't had many patients that necessarily need to go down that road. And then there's a whole bunch of other medications. Let's go ahead and let's look at LexiComp first. So this is the tool that we use in the office. Whenever I have a suspicion that there might be a drug interaction, and cyclobenzaprine does fall under the category of medications where I'm more suspicious, therefore I want to use this tool. For those in the office, we have access to LexiComp. Just let me know. I have the username and password for the office. And then you can enter the drug interactions in the Alerts and Interactions tab in the upper left, where you see that yellow box. Super helpful. We do it for every one of our sedation patients. If you've ever looked in the sedation packets that we have during those appointments, we have a printout of all of the sedation medications that we're prescribing, all of the medications the patients are on, and then all of the interactions or potential interactions, so that we can, those that are doing the sedation can customize and modify the treatment accordingly. Topic for another day. Point is, LexiComp is super powerful and something I would never live without. I want to go back to this guy. Anytime I have a question medically, whether it's medications, drug classes, diagnoses from a medical perspective, I break out this book. I'm pretty sure we've all seen it. If you don't have it, you should have it. It's like the safety blanket for the general dentist that's doing anything, really. How many people can articulate with precision exactly why a patient on amitriptyline should not get epinephrine? I promise you, if you try to look that up online, you're not going to find the answer. The answer is in this book. So things like that, I find this book to be very, very valuable. Anybody want to chime in on the value of this book? Is this a surprise? You used it today and saved your life? All right, I'll assume everybody's used it. All right, any questions about Flexerol? Again, it's used for myofascial pain disorder, Charlie horses of the masseter, and they're primarily relegated for situations in the acute state.
I had one question, Dr. Roy.
All right, Dr. Labonte.
I had a patient in Naples, which prompted this whole Flexerol conversation, that Dr. Brown used to prescribe her before any treatment. She clenches, and when she opens her mouth open for a wide period of time for a dental appointment, she knows that it takes her days to recover from.
Sure.
If you're going to be prescribing it for, let's just say, a day or 2 days, is it still just the dispense 3 for the day? Do you have the patient take it the night before to kind of prime the receptors? Do you take it the morning of, an hour before? What's a good protocol?
Yeah, great question. I was speaking more about pathology. You're speaking more about, or maybe not pathology, but pathology and pathophysiology. You're speaking more about just patient care. Yeah, it's absolutely a tool. I have used it in the following manner with success. I have looked for literature to guide us in that. I definitely did a deep dive once upon a time and I didn't find much. So much of my recommendation for this purpose has to do with anecdotal evidence coming from my mentors, and it's to do exactly what you just said. So I'll do 3 pills. They take 1 the night before to prime the receptors. The half-life it's a little bit different than the priming the receptors for benzodiazepines, like we use it for sedation. With that said, it does increase the blood levels so that the medication works more predictably the next day. The pharmacology and the mechanism of action of these drugs is not very well understood, so it's hard to say whether or not that dose the night before is necessary or not. I've done it and it's worked well, where I do 3 pills. They take 1 the night before, 1 an hour before the appointment, and then they bring the other pill in case they tighten up during the appointment. And I have used that 3rd pill. Most of the patients with this, just like you articulated, they have some experience with this protocol, so they kind of know through trial and error what works best for them, whether or not they should be driving or not. I do think that there's enough evidence that these medications cause drowsiness to the point that they probably shouldn't be driving. So I'll let you resolve that. I do know many people still do. I know many doctors who prescribe it not worrying about it. With that said, I'm not an expert in the medical legal aspects of this drug, so I'll let you kind of divulge that any way you'd like. I would be careful with it is really my take-home message. So yeah, three pills. I would be okay giving several refills so that the patient's not having to call the office all the time. These potentially have abuse potential, but in a 65-year-old postmenopausal lady, I'm not sure I'd be too concerned about it, but it is something to keep in mind.
Can I chime in, Doc?
Yeah, absolutely.
No, when I had my back freak out on me, they gave me cyclobenzaprine as part of one of the things they did. They gave me 5 milligram tabs. So a couple of things, just if you guys have never taken it or never had a side effect from it, if you did take it, definitely interesting because I ended up with a dry mouth, but after about a week. It was funny. I was working on a patient, and I hadn't taken any since the day before because I wouldn't take it in work. After I took one on the weekend, I determined it zonked me, just one. So I decided not to drive anywhere or do anything, and I didn't work with it. So I only took it at night basically before I went to bed. But I realized that in the morning, I was at work and my whole mouth was just super arid, like dry. I was like just trying to drink of water. It took me a minute to figure out why, but I realized it was a cyclobenzaprine. So if you ever do give it to somebody and they freak out over the dry mouth thing, it was definitely real.
Sure wasn't the bender you had the night before?
Definitely wasn't that, but no, but it definitely I would caution I would caution people with driving if they're on a 5 milligram dose like I was. Like I said, I was only taking it at night, so
yeah, you're not a small individual, although
lightweight.
Yeah. One important thing, and I'm glad this came up. The size of the individual has many times very little to do with the pharmacodynamics of a drug. If they are highly lipophilic, there is a role there. With that said, I've seen very old ladies that need a lot of medication. I say very old ladies. Frail, 100-pound soaking wet ladies that need a lot of medication. And I've seen linebacker type individuals that are 30 that are lightweights. So there's much more to it. And I think it's important to understand as we give medications, the size of the individual is only a small factor with many medications. Luke, case in point. All right, let's move on. Another question that came up today was the following. Let's say you have a patient that was prescribed an antibiotic by the ER. In this case, it was erythromycin. And we know erythromycin is not very specific to the bacteria that harbor dental infections. Therefore, the clinician, the dental clinician, then had the question, I would prefer the patient be on amoxicillin because of the more applicable antibiotic profile, do I discontinue the erythromycin or continue it along with the amoxicillin? So this would be version 1, discontinuing the erythromycin. Version 2, continue the erythromycin until it's gone, and then continue the amoxicillin. Maybe these two arrows don't end at the same time. I probably should have thought of that when I did the arrows. The point is, do you continue with the erythromycin even though you don't think the coverage is necessarily relevant? So here are the two examples. Anybody want to chime in on what they think? Did this ever come up in school?
So somebody else, like maybe a ER doc, gave erythromycin for dental infection. Is that what you're saying?
Correct.
Is there any allergies to be worried about?
None.
I don't know. I see them prescribing Pembrolizumab all the time, and if it doesn't affect anything, I always switch them to amoxicillin or Augmentin.
So you'll switch from penicillin to Augmentin?
From like a lot of times the ER docs will do a Pembrolizumab.
Yep.
That's what we see, which is fine. It was done for a long time, but if it's not responding and they come into me because it's gotten worse, I'll usually switch them to an Augmentin.
Okay.
And I'll tell them to stop.
Anybody else have any thoughts? I definitely have some comments there.
I usually just, if that was the case, I would switch them out and just have them stop the erythromycin.
Okay.
I guess I'm more get something that works better and have fewer antibiotics on board to cause GI distress and recurrent C. diff.
Yep.
I've always learned through a few different sources to keep them on what they are on until proven otherwise that they need it. So I usually, if patients come all the time, oh, the ER doc prescribed this, I'm in 2 days into it or 3 days into it, I'll say continue taking it. If you notice no resolution, please let me know.
Let's say they have no resolution. Do you discontinue the medication at that point and then switch it out for a new one?
Well, I mean, if it's only like 3 days in, I know that's still not enough time for some antibiotics to kick in. So I'd rather, give it 5, 6, 7 days, finish their course essentially before making that decision.
Sure. Yeah, this was a great question. It's come across my clinical experience many times. The chart and what I'm about to share is my experience and what I would do myself. I promise you this is not the answer. So I definitely am ready to get a counter argument here. But I always go back to this chart here, and this is a very oversimplified graph to kind of paint the picture about what coverage really means. We have to be really careful when we say we're just going to switch one antibiotic to another. They're not all the same. They're not even close to the same. They don't work the same. They don't target the same bacteria. Some kill the bacteria. Some slow down their protein synthesis. I think we understand these facts. So the point is, if you discontinue one and you replace it with another, if they don't work in a similar fashion, you're 100% opening the door for creating antibiotic resistant strains. Now, what makes this difficult, clinically, nobody's ever going to know that happens. So there's no doctor who's ever prescribed erythromycin and then another doctor came along and said, discontinue the erythromycin. All of a sudden, this bad thing happened and everybody says, Dr. A should have done this and Dr. B should have done that. It's a very ambiguous and amorphous thing to quantify. The point is, if we want to be very good stewards of antibiotic, I think we should answer this question very specifically, and I would love to see if anybody has any infection control specialist that can answer this question. But what I would say is, if the medication is in a different drug class, continue with the original one. If for whatever reason you're going to keep them in the same drug class, penicillin to amoxicillin, for example, although I don't see the rationale to do that, and I'll share my whole spiel on why I think penicillin is better than amoxicillin. And I know I'm on an island with that, maybe with those ER docs. But the reality is these drugs work differently, and the propensity for antibiotic-resistant strains to emerge is irrelevant to the new antibiotic that you prescribe, if they work differently. I now open the door for counter arguments. I'd love to hear what people think. All right.
So can you repeat again your logic for penicillin over amoxicillin?
Sure. So different conversation, although slightly related. Penicillin is a narrower, broad-spectrum antibiotic. Amoxicillin is a broader, broad-spectrum antibiotic. The rationale that I once heard, and I've heard it repeated by people that I think know what they're talking about, said something to the effect of penicillin is like a laser beam for the bacteria that we see in the mouth most of the time. And they're still it's still somewhat broad spectrum. Whereas amoxicillin, it has more coverage, but it's covering things that are maybe less likely to show up in an odontogenic infection. Absolutely amoxicillin works, but I think where amoxicillin gained traction, and this study was very clearly done maybe 10 years ago, and it had to do with compliance. When you compare penicillin to amoxicillin, if the patient is taking the penicillin 4 times a day, penicillin is better than amoxicillin. But if you add compliance in there, if you know the patient is not likely to be compliant, 875 amoxicillin twice a day is far better than penicillin 4 times a day, but the patient is only taking it twice a day. So what happened was clinicians started saying, you know what, all of my patients don't take these medications, so I'm going to start giving amoxicillin over penicillin, PenVK specifically. And when I say penicillin, I'm specifically talking about PenVK. In my experience, many clinicians from many schools have come to the office and prescribed amoxicillin, and I've had situations where penicillin actually was the medication that worked where amoxicillin didn't. With that said, I've seen it work the other way around too. The point being, the literature is pretty clear penicillin's the better play if the patient's going to take it 4 times a day because of the pharmacodynamics that are involved with penicillin. It has to be taken more regularly. Amoxicillin has a better chance to stay in the bloodstream for a longer period of time, therefore longer effectiveness at lesser frequency of dosing.
Yeah, that makes sense.
Can I chime in on that real quick?
Yeah, go ahead, Chad.
Something as well that I learned along that same line is that a good way to start is with PenVK, because then it still gives you amoxicillin in your back pocket just in case. If you start with amoxicillin, then you don't really have much in your back pocket. So like if you have to refer someone to endo, or if you just can't see them for treatment soon enough, if you start with penicillin, then 2 weeks goes by, they still haven't gotten treatment, the infection is getting worse, then you still have amoxicillin to prescribe them, if that makes sense.
Yeah, I don't know.
Is that logical?
I don't know if I would go to amoxicillin if penicillin didn't work, because they're kind of similar.
Yeah.
If penicillin didn't work, I'm going to assume there's a gram-negative component. Anybody want to take a guess at what I'm going to throw at it?
Clinda?
Augmented?
Clinda's good. Very good answer. Because Clinda has quite a bit of gram-negative coverage, I would probably use Z-Pak these days, where Clinda's really falling favor. I mean, really in the past 3 years, there's been quite a strong surgence in not using Clinda anymore because of its GI upset. But from an antibiotic perspective, that's a great play. Chad, there was something you were going to say?
Oh, no. That makes more sense, though.
Yeah. Van Winklehoff cocktail, ring a bell?
I heard of it, but I couldn't tell you. I don't remember.
All right. So Van Winklehoff cocktail was developed in the perio community. Christian and Luke must not be paying attention because I know they know the answer to this. Metronidazole. So metronidazole is a purely gram-negative antibiotic. So if you give penicillin and they're not responding, 9 times out of 10, it's because there's gram negatives involved. And oftentimes you'll know that. You'll just see the infection. It just looks long-standing. It's a very long, very large periapical abscess that has no communication with the oral environment. Those are where the gram negatives and the anaerobes tend to hang out. Metronidazole, also known as Flagyl, has very specific gram negative coverage. The Van Winklehoff cocktail came out of the perio community because deep perio pockets tend to have a lot of gram negative bacteria in them. The combination of amoxicillin and metronidazole together is called the Van Winklehoff cocktail, and it's used in the treatment of chronic periodontitis, sometimes as an adjunct to active periotherapy. The reason I bring it up here, we've used it for situations like that all the time. So we'll give either penicillin or amoxicillin. If they don't respond, we'll add metronidazole, and 9 times out of 10 that does it. They continue with the penicillin and or the amoxicillin. But going from penicillin to amoxicillin, again, I may be wrong. I'm not an expert in infection control, but that doesn't really stand to reason that you're using two drugs that have very similar mechanisms of action and very similar coverage. With that said, penicillin is a little more accurate when it comes to the strains that you see in most odontogenic infections, if they take it regularly. Amoxicillin works great too. Absolutely nothing wrong with amoxicillin, but I wouldn't switch from one to the other. You're more likely to cause an issue there just due to the slight discrepancy between the two.
Can I ask a question?
Go for it.
So if the patient was on Pen VK,
Yep.
even though you just said you prefer amoxicillin with adding metronidazole in those cases, and it was like they were like 5 days in,
Yep.
and wasn't quite working, that's when you would add it on. So if they,
Correct.
like, how many more days would you, let's say it was a 7-day prescription of Pen VK, obviously 2 days of metronidazole is not enough. So would you also lengthen their Pen VK and keep them on? Do you know what I mean?
Yeah. I'll admit I'm not qualified to give you an exact answer. This has come up.
I
in
guess
the
what's your
office.
goal of having them on it? Like, what's the shortest amount of time you would want them on something before you were comfortable?
I would do 7 days. So I'm okay.
7,
Yeah,
okay.
if you did penicillin 7 days, and then at day 5 you're not noticing the resolution that you would expect, I would do a 7-day course of metronidazole, and then consider either an additional 3 days of the penicillin. But I've not done that, and I've had success. With that said, I think it would be safer to have the patient take 3 extra days of penicillin, so that you're getting at least 5 to 7 days of dual coverage. Exactly.
Okay.
Yep.
Thank you.
You got it. Now, another thing that came up is Augmentin. Augmentin is expensive. I don't know kind of where it sits in the realm of insurance coverage, but I do know that it's not necessarily as covered. Augmentin has clavulanic acid in it, so it's amoxicillin plus clavulanic acid. Why do we put in clavulanic acid?
It makes it more potent. Is that wrong?
Good guess. All right. So do we remember the term beta-lactamase? So beta-lactams is the chemical structure that we see with the penicillin group. So there's a kind of like a 5-carbon group that forms a beta-lactam, for lack of a better term. It's the chemical structure of the antibiotic. There are certain bacteria that produce beta-lactamase enzymes that break down penicillin or amoxicillin. Those bacteria are typically found in the sinus, not necessarily the mouth. Therefore, we don't really use Augmentin because of this fact, because we don't need the clavulanic acid, which deactivates the beta-lactamases, because most odontogenic infections are not involved with the sinus. We do use Augmentin a lot when we do sinus surgery. We also use it if there is a periapical abscess that may or may not be involved with the sinus. With that said, is it bad to use Augmentin? Absolutely not. There's nothing with the clavulanic acid that's going to create antibiotic resistance. So that's an important thing to remember. If you're unsure, go with Augmentin, but I would recommend not using it as a regular antibiotic because of its cost, unless there's a potential involvement with the sinus. Sound good?
Sounds good. I was going with the advice of my surgeon. So I was following that, but that makes sense.
Yeah, I mean, you get 10, I say this all the time, you get 10 doctors in a room, you're going to get 15 opinions.
Right.
I'll be honest, even the surgeons, I don't think necessarily, I'm not saying I'm better than the surgeons, please understand that's not what I'm saying, but the average clinician does not dive into rationale as much as we just did. That's a fact. If you're going to follow the lines of reasoning of others, you might be following a line of reasoning 10 people deep. In other words, one person believed another person that believed another person that believed another person. All of a sudden you're doing something, and it's almost like that game Telephone where at the end of it, it's a completely different story. As a clinician, it's somewhat within our duty to understand a little bit more about this stuff. And I'm not trying to knock you down at all, Kristen. I think this is great. These are awesome questions. Heck, it's the reason why we're doing this. Maybe poke your surgeon and say, hey, why do you recommend Augmentin? Was that the recommendation as a first line defense?
As opposed to the Pen VK. Yep.
Yeah.
It was a huge facial swelling and so.
If there was a situation, facial swelling that may or may not have involved the sinus, then absolutely. And maybe their recommendation was based upon the high likelihood that there was some involvement with the sinus. I would be curious to see what they thought about that. I've also talked to oral surgeons, and they said the only time they use it is when they do sinus surgery. With that said, the goal of us is just to understand this stuff and be judicious as we prescribe it. There's no right answer every time, but there is definitely an underlying foundation of knowledge that I think all of us are a little closer to getting to the ideal after looking at this chart. So I saved this chart, kind of confusing, but it paints a picture of what coverages really mean. One important thing about this chart, it's overly simplified. Penicillin doesn't cover all gram-positives. So this is kind of a black and white coverage chart. These charts can get rather complex as they get more and more accurate. This is a 10,000 foot view chart. All right, anybody else with antibiotics? 40 minutes on pharmacology. Holy moly. All right, so last time we talked about adhesives. We started to have the conversation. We only have 20 minutes, so I'm going to paraphrase what we talked about, and it was the fact that many dentists don't understand. Man, I feel rather condescending after having that conversation. These are facts. This was a poll that I did back in 2015 asking dentists what they knew about their dental adhesives. The take-home message is this. Do you consider your knowledge about dental adhesives to be sufficient? 23%. Ed Swift, I've seen him talk twice, an amazing clinician. He understands the science of dental adhesives as well as anybody. And he wrote, unfortunately, many clinicians fail to follow directions, this being one of the most important things when it comes to understanding your adhesive. Not following the directions about what you learned in school, but the adhesive that you're using in the chair that day. So many clinicians fail to follow directions provided by the manufacturer and either intentionally or unintentionally misuse bonding systems. Probably more unintentionally. I have heard countless clinicians say, I use whatever's on sale. I'm not kidding. As you guys spend more time at CE, you're going to hear people say those things. It's absolutely mind-blowing. Everybody that's here today is here because they want to be better. They probably already understand this stuff, but I want to make the point that this is rampant throughout the profession. Adhesives are misused all of the time. So this was the lecture I gave back in 2016 at the Greater Portland Dental Society. My goal is to improve the world of dentistry through education in adhesive dentistry. I did a podcast with Howard Ferron on Dentaltown on my beliefs. I have a bachelor's in chemistry, so I'm somewhat qualified to opine on this stuff. With that said, I struggle just like the rest of us when it comes to how to use a bond in everyday practice so that it sticks and the patients don't have sensitivity and recurrent decay. We've all seen stuff like this. Last time we went over the fact that enamel bonding is kind of like this, whereas dentin bonding is the opposite. They're two different animals. And understanding that these surfaces are different is very critical. If somebody ever asks you, what is the best adhesive for dentistry? Ask them, what substrate are you referring to? It really matters. They're two completely different animals. If somebody asks me, what am I going to use to bond a CEREC crown or an Emax crown on this tooth? The adhesive I'm going to use here under ideal conditions is going to be very different than the adhesive I'm going to do a resin class 2 composite here in a slightly aqueous environment on dentin. Point of the story, not all substrates are created equal. Here's another example. 360 degree rim of enamel, you can do with your left hand, throw some water in there, undercure it, and you're still going to be fine. Notice I'm sensationalizing a little bit. The point is that 360 degree rims of enamel are your friends. The moment you get past the CEJ and you're into dentin or cementum, it's a whole different animal, which is why things like margin elevation, open sandwich techniques, so on and so forth, are so relevant. But are they relevant? Are they relevant in your practice? Anybody want to provide any comments about substrates being unequal? Everybody's sleeping. I love this right here. This is a very simple diagram I got off the internet years ago. The dentin bonding agent. Now we're talking about dentin. From this point forward, we're not talking about enamel. Enamel bonding, again, is easy. Dentin bonding is hard. Dentin bonding agent is it's a biphasic molecule, meaning it has two different ends. Ideally, one is hydrophilic to get into the water located in the dentin, whereas there's a hydrophobic end which bonds to the composite. This was a little analogy that I used. The hybrid layer is the boat, the composite or the flowable is the hydrophobic end. That's me out of the water, whereas the dentin is a hydrophilic area. It's the fish. The goal is to create almost something like Velcro. When I think of the hybrid layer, my head goes to this. We want a micromechanical interaction between the composite and the dentin, the collagen microfibrils that are located in them. We all know there's not a covalent bond. There's more to that story. But the micromechanical bond in the hybrid layer is not a covalent bond. It's a micromechanical bond. Anybody want to throw out why is that substantial? This is super important. If it's not covalent, why is that important?
Because you're not relying on the chemical bond, you're relying on in a covalent bond, whereas with a micromechanical, you're relying a little bit more on the mechanical aspect. Is that, I don't know, I'm reaching.
Well,
that would be my guess.
Well, Elena, thank you for chiming in. You know, most of the time when I ask questions, because I it took me years to kind of figure this stuff out.
Is it like welding something versus just bolting it on and you're hoping the friction holds it there?
So I think the two of your answers together would probably be it. How
Then you
about
have to
this?
get the dentin tubules open so and engage it.
Say that one more time, Mark, because all of this.
Sorry.
Go
Is
ahead.
it so you can get the dentin tubules opened to engage it with the mechanical part? You're not chemically bonding to the outer surface?
Also true. Let's just say there is proper penetration in the tubules like we see right here. What do you notice right here? There's a gap. Is that gap a covalent bond? No. I'll just share that. The dental adhesives on dentin is not a covalent bond, therefore water can travel through it. And when water can travel through it, so do matrix metalloproteinases. And what do those MMPs do? They break down the collagen in the hybrid layer. Whether you're in the dentinal tubules or not, when you don't have a covalent bond, you have leakage over time. That leakage brings in bad things. It can bring in bacteria, can bring in all kinds of things, but specifically it brings in MMPs. We've all heard MMPs. MMPs break down the collagen. MMPs are a form of collagenase. They break down the collagen in the hybrid layer, thereby degrading the strength of the bond over time. And we call that micro leakage. And there's been lots of studies over the years that measure the micro leakage, literally from the dentin cavosurface margin. They'll actually measure with silver nitrate how much and how far in fluid penetrates into this hybrid layer. And one can surmise if there's fluid in there, there's degradation of the bond. Why do we use chlorhexidine as a pre-bonding agent?
To inhibit the MMPs.
There you go. Beautiful. So Chad hit the nail on the head. The MMPs are the things that break down the bond. Chlorhexidine has been shown to decrease the activity of MMPs, thereby stabilizing the bond. Unfortunately, so there's some recent studies that showed that effect is only relevant for a year, around 12 to 18 months. With that said, I think it's good that we use chlorhexidine for that purpose. If somebody asks me, do you want chlorhexidine or not? It gives you 18 months of coverage. Absolutely, I'm going to want that. So chlorhexidine is a factor in this. Now, what's important is, and maybe I find a different slide to go over this. I'm going to plant a seed, and that seed is, what is most important? The bond on day one, or the bond on day, pick a number, at some point in the distant future. 99% of the advertisements that come from companies like this, you're going to see things that say certain megapascals. Here we go. This is what I was looking for. These are all kinds of different adhesives This is it right here. All right. All of these different adhesives, here's the megapascal strength. But the megapascal strength of what? The initial bond strength. If you read these articles, you're going to see the term initial bond strength all the time. Here's another one. In megapascals. Well, I'm not interested in initial bond strength because what it is on day one is not really what's going to save the day for me. If we have micro leakage, I want to know how stable that bond is. That's the factor I want to know. So the whole point of this lecture that I gave was initial bond strengths as a way to sell an adhesive is irrelevant because of the fact that they leak. It's more relevant how they perform over time and how resistant they are to degradation. That's more important. Did that make sense, or did I confuse everybody?
Makes sense.
Makes sense.
So again, it's the strength of the bond over time. So we're going to come back to that. When we talk about different generations of adhesives, some generations perform better with longevities of bond than others. Back in the early 1990s, the 4th generation came out. That is your three-step products. OptiBond FL being the kind of the gold standard in that generation. OptiBond FL is an excellent adhesive. It's been considered the gold standard along with Clearfill SE, which is a 6th generation. It's an etch, rinse, primer, adhesive, cure, 3 steps. The 5th generation took the primer and the adhesive and combined them together. So you have your etch and then your 2-step in one bottle. So here, combined primer and adhesive. Prime and Bond NT was probably the most common one. OptiBond Solo Plus was another. These are adhesives that were common when I was in dental school. Then came along the 6th generation where the etch was removed, and in the 6th generation the etch comes from the primer, and then you apply the adhesive and then you cure. 7th generation said, let's put everything in one bottle and see if we can get it all to work. Please, for the love of God, do not use these. I spend probably 5 slides on why. It's been proven without question that these leak more than anything. So try not to simplify the dentistry for your patients to the point that you're actually compromising their care. Then came the universal adhesives. And this is probably what most of us are using right now. Scotch Bond Universal, All Bond Universal from Bisco. Those are the 2 that we use. They fall under the universal realm. Sometimes the universal is misconstrued as the 8th generation. That's not correct. The 8th generation was a self-termed generation from a company called Voco. I had a slide earlier on what they have. They called it Futurabond DC. You don't need a light for this. It's purely, you just apply it and then you start doing your dentistry. So this is a true all-in-one adhesive. I don't know if it exists anymore, but when you hear 8th generation, just know that there is very few products out there on the market that have been tried and true, if any. What separates a universal from these others? There's 2 things. The first has to do with the fact that you can do what's called multimodal application. You can total etch it, you can self etch it, you can selective etch it, and you can do 1 or 2 steps. Point being, you can use it just like you would in any of these other generations, and it'll work. So it's a multimodal generation of adhesives. I don't know if that's super valuable. It's a great marketing ploy. And as many of these companies know, the more they can combine things into single steps, the more likely they are to sell. I think our patients deserve more from us than that. The other factor that separates the universal is something called MDP. MDP is a chemical. And here comes the full circle. MDP is a chemical that does what? Give you a hint. It's not van der Waal forces. So covalent forces. Universal adhesives contain MDP, and MDP has been shown to covalently bond to dental substrates, including dentin. Why is that important? Let's go back to our little slide here. We're more likely to get covalent bonds here, which is likely to decrease micro leakage. As a result, we're likely to have better long-term bond strengths over time, not out of the bottle, but over time. Who would like to share? What are some other things universal bonding agents claim? And it has to do with MDP. MDP has been shown to bond to many things: metals, ceramics, enamel, dentin. There's lots of different applications for it, but what I will say is just because a company says you can bond to something does not necessarily mean that it will last. So let's go to this here. Bond strengths in megapascals based upon microtensile forces. We can go over that maybe next week. What are the different forces that are applied to dentin bonding agents to determine their clinical performance? These were microtensile bond strengths. The 7th generation had somewhere around 15 to 20 megapascals. That's not very good. Combined with the fact that this generation leaks a lot, that 20 is going to turn into 5 real fast. The 6th generation was higher at 27. The 6th generation actually has the least amount of leakage over time because many of the 6th generations actually contain MDP. MDP being that thing we find in our universal adhesives, and universals are not here. This study was done before, actually it was 2010. Universals came out in 2011. The point being that the reason why the bond strengths are higher in 6th generation has to do with the fact of the MDP. I actually like this class the best. They're also the most technique sensitive, unfortunately. With that said, if somebody was to do a filling on me, I would ask for the 6th generation. 5th generation, we see a little bit of a loss here. These also leak a little bit more than both the 6th and the 4th. The 4th is your gold standard, but it's the most steps. With that said, still very good, except for the fact there's no MDP in it. What's the moral of the story here? Universal adhesives have really combined all of the strengths of all of the generations before 2010, simplified it for us so that predictable clinical dentistry can be done in the hands of most clinicians, even the clinicians that don't understand what their directions are. So I started with many dentists clearly don't understand how to use the tools they have. The companies knew this, and that's why they came up with the universal adhesive system. And I don't think there's a degradation in the quality of the dentin bond with universal adhesives if they're used well. Universal adhesives, some of the studies that have been coming out, initial bond strengths with these similar tests come around 30 megapascals. So their performance is right where the best of these previous generations are. So I'm going to stop there. There's 120 more slides. Anybody want to comment on this so far? Was this clinically relevant for you?
Yeah, I mean, kind of do this every day.
Yeah, for sure.
How many people, and just answer this question in your own head. Can you say with conviction exactly the directions of your bonding agent?
Nope.
No.
No.
So let's all tomorrow open up the flyer that comes with the bonding agent, or maybe look tonight, read the directions, and just see how far away from the application of the bonding agent you were. Most likely you were using techniques that you were taught in dental school with maybe a completely different class of adhesives. Let's all tonight upgrade our clinical application by reading the directions with our specific adhesive. If you're not using universal adhesives, I do think there's a lot of value there. If you're using OptiBond FL, stick with it. It's one of the best out there. If you're using Clearfield SE, stick with it. One of the best out there. If you're using anything else, maybe consider the universal adhesives. Both Bisco and 3M are at the top of my list for a multitude of reasons, but there's still some very good ones out there as long as they contain MDP. MDP is the key because of that covalent bond. On that note, after a 2-week hiatus, hopefully we provided some value tonight. Please send questions. I'm going to start having a kind of like a poll at the end of these to see what kind of value I brought. I don't know. I get excited about this stuff. I love sharing it. I openly admit that I might be wrong from time to time. I promise you that even if I'm wrong, the stimulation in the arguments that we have is going to make every one of us better dentists, and that's all I really care about. So I hope that everybody goes back to the literature, goes back to their textbooks, and we all become better dentists because of the conversation we had tonight.
Thank you.
Thanks,
All
Doc.
Thank you.
Good night.
Have a good one.
Thank you.